Hi out there to everyone listening. I hope you guys are doing all right and keeping your spirits up as much as you can in these confusing and what are occasionally dark times. My name is Tyler Tate, and I'm faculty at Oregon Health and Science University, where I work as a pediatrician and palliative care doctor, as well as the director of Professionalism and Comfort Care at the Center for Ethics in Healthcare. Today, I'm going to take a few minutes to talk to you about an uncomfortable and distressing kind of experience that many of us in healthcare may have heard others talking about or may have experienced ourselves during these challenging times of the COVID-19 pandemic. The experience that I will be talking about is called moral distress. Now, over the past 1 or 2 decades, the topic of moral distress in medicine has become popular as a topic for discussion, both among healthcare providers like nurses, physicians, and others, as well as journalists and other pundits who write about medicine. However, although it's frequently discussed and often in contrast to its relatives, moral injury and moral fatigue, the idea of moral distress itself can actually be pretty vague. But before I start talking about moral distress directly, I want to tell you two stories. Imagine you are the pediatric oncologist taking care of a 10-year-old girl named Lucy. Lucy is hospitalized with leukemia. She has actually had leukemia a long time and has gotten 2 different bone marrow transplants in the past. However, her cancer came back and now her immune system doesn't work after getting a ton of chemotherapy. She's in the hospital this time with a bad pneumonia and she's getting sicker every day. Her parents are hoping that the antibiotics she's getting will pull her through. However, they also know that there's a good chance she will die during the next 2 weeks. This obviously makes Lucy's parents incredibly sad. But the thing that makes them the most sad and frustrated is that because of visitation restrictions due to COVID precautions, only one of them can be with Lucy at any one time. And you, her oncologist, are the one who actually has to tell them that they cannot both be present with Lucy at once, unless they actually change her code status to do not resuscitate and switch her to comfort care. They tell you that you are cruel, that you are stealing time from them, and that you are forcing them to give up on their daughter prematurely, just so they can even spend time with her. Or imagine you're the nurse of Martha. Martha is 82 years old and is dying in the intensive care unit from respiratory failure due to COVID-19. Before getting picked up in the ambulance, Martha had told Thomas, her husband of 58 years, that she would not want a breathing tube if it came to that. For the last 24 hours, she's gotten progressively sleepier while working harder and harder to breathe. Her ICU team is giving her small doses of morphine to help her not feel short of breath. However, whenever she does wake up for a few moments, she grabs your hand, cries out for Thomas, and asks you why he isn't there with her. You try to explain that because of COVID, he cannot come see her or even enter the hospital. You also try to FaceTime Thomas in so he can say goodbye. When you do, Thomas is sobbing and angry, and Martha is too confused to even recognize him. A few hours later, Martha dies. A month later, your unit gets a letter from Thomas saying he will never forgive the ICU for forcing his wife to die without anyone she knew by her side. These kind of events have, tragically, become pretty common stories of what has been occurring and continues to occur in hospitals all across our country and the world during this time of heightened visitation restrictions due to COVID-19. And while the toll of these restrictions are enormous on families, on parents, on spouses like Thomas, For the rest of this talk, I'm going to focus on the toll it is taking, actually, on our very own healthcare providers. You see, it's really, really hard to tell a parent or spouse that they cannot be with their loved one when they're hospitalized. And I know from personally having to do this several times over the past few weeks, it feels honestly just wrong. For me, it felt like I was committing an indecency. I was harming a person, and I was failing to honor my duty and calling as a physician to advocate for my patients, regardless of the circumstances or context. That feeling that I and many other medical providers have felt over the past few weeks in situations such as these can be called moral distress. And today I just want to briefly explain and explore what moral distress is, and maybe later talk about ways clinicians can decrease moral distress. Moral distress was first talked about in the 1980s as something nurses experienced when they were ordered to do things they believed were morally wrong or harmful to patients. Its original definition was painful feelings and or psychological disequilibrium that occurs when nurses are conscious of the morally appropriate action a situation requires but cannot carry out that action because of institutional obstacles. You can see how this creates a similar feeling to what a doctor or a nurse has to tell a patient or parent or spouse or their loved one when they cannot all be at bedside. A family holding the hand of their child, partner with their partner, or some other relative. It's the feeling of distress that accompanies knowing what you ought to do, but being unable to do it. Yet this doesn't tell the whole story either. As my good friend, the philosopher Gina Campaglia, describes it, moral distress isn't just about being forced to do what you think is wrong or what you think is not best for a patient. It's also about just simply not knowing what to do in the face of uncertainty. And the thing is, in my experience, clinicians aren't that great at dealing with uncertainty. We want things to be black and white, for there to be a protocol or algorithm to follow. However, when I'm trying to weigh the benefits of enforcing a strict visitation policy in order to prevent the spread of coronavirus with the harms done to patients and families that are separated from each other in their moments of greatest suffering, fear, and need, what kind of scale can I even reach for? How can a clinician make that decision? Or even if they're not the ones ultimately making the decision, how can they be the ones who enforce the policy? As if being on the front lines of disease, having to deal with illness, death, and dying on a daily basis was not hard enough. Now we have to be the bad guy and separate people from each other when things are at their most dire. So, what can we healthcare providers do about these feelings of moral distress, this feeling that we are caught in the horns of a dilemma? We are damned if we do, but also damned if we do not. Well, for now, I'll offer 3 brief words of advice, or you might say encouragement. First, name it. By this, I mean name the situation. Moral distress, as I see it, arises in situations where both options feel like bad options. This is called a dilemma. And in dilemmas, in a very real sense, both options are bad options, and there is nothing you can do about it. But by naming the dilemma for what it is, we acknowledge that the badness is built into the very structure of the situation, and that it is not, therefore, the result of an evil, say, person. So, we should not vilify anyone, including ourselves, since it is probably not any person's fault. And this can help us learn not to blame ourselves or others when people are not happy with the outcome. Second, share the decision. Morally challenging situations should never be made in a vacuum. Neither should they ever be enacted or enforced by one person. And third, support each other. These are hard, challenging days. Friendship, especially with coworkers and peers who understand what you are going through and who can both validate your actions and help carry some of the moral burden of care, is crucial. Moral distress cannot be borne alone. Thank you all for listening, and a special thank you for the support I receive in my position from the Miles J. Edwards Chair in Professionalism and Comfort Care. Have a good day.